Hi, I'm Amber Luong. I am a rhinologist at the McGovern Medical School at the University of Texas Health Science Center. And today I'm going to talk to you about allergic fungal rhinosinusitis, presentation, diagnosis, and management. Here are my disclosures, none of which will have any impact on today's discussion. So for the next 30 or so minutes, for 30 to 40 minutes, I'm going to give you an introduction on the history of allergic fungal rhinosinusitis, its clinical presentation, how do we make the diagnosis of classic allergic fungal rhinosinusitis, and then talk about the treatment and some of the tips that are important when managing allergic fungal rhinosinusitis. So in 1987, a paper by Katazenstein in 1987 sort of formally described this entity of allergic fungal rhinosinusitis. In this relatively short paper, it describes 15 patients who have this classic presentation. So they were all relatively young, less than 30 years of age, and they had some of these classic symptoms, or they had polyps from the nose. They had this eosinophilic mucin, of which 85% or so had aspergillus that were culture positive from them. They talk about the fungal sensitivity of these patients and discuss some of the similarities, and hence the similarity in the naming of allergic fungal rhinosinusitis to the lower airway, what they considered equivalent of allergic bronchopulmonary aspergillosis. And so this is the first sort of formal description of this entity. So it's a relatively new phenotype that was described about 40 years ago. So based on this presentation, Benton-Kuhn formalized the diagnostic criteria, and it's probably the most well-accepted diagnostic criteria for allergic fungal rhinosinusitis. So let's go over that. So as discussed, the first criteria is the presence of nasal polyps. In fact, allergic fungal rhinosinusitis is considered a phenotype. And now as we're getting more of the understanding the molecular pathways involved in allergic fungal rhinosinusitis, it seems to be a unique endotype of CRS with nasal polyps. As mentioned, it has a demonstration of type 1 hypersensitivity to fungal antigens, and this can be denoted based on either a skin test or elevated serum fungal specific IgE levels. Another thing that we'll go over and highlight and show are some of the characteristic imaging, both on CT and MRI, but you'll see this heterogeneity of the signaling of the opacification of the involved sinuses, which is indicative of the eosinophilic mucin, and you'll see some of the classic expansion and a thinning of the bone because of this expansion that's associated with allergic fungal. Another criteria is this presence of eosinophilic mucin, which I'll show you in a video later on, that shows a lot of the fungal hyphae, as well as when you culture this, the mucin, you'll get positive fungal cultures from this mucin. You'll see also presence of eosinophils and the Charcot-Leyden crystals, which are basically degranulated eosinophils. So this is the criteria for the classic allergic fungal rhinosinusitis, and is the most widely accepted criteria for AFRS. So one unique thing about allergic fungal that you don't see in other CRS with nasal polyps is this ability to present with unilateral disease. So at least in my mind, it really highlights the environmental component of this disease, right? The fact that it can present on one side versus bilateral. So it really highlights this role of fungus and the in either triggering or perpetuating the inflammation of the sinus cavities. So let me show you here. So this is a classic picture of a unilateral presentation. And obviously this is going to have implications not only in the ability to diagnose this disease, but also in its surgical management. So as you can see here, some of these other features that are unique to allergic fungal rhinosinusitis, as I mentioned before, this expansion of the sinus cavity. So you can see the bowing of the septum here on the patient's left towards the right, and also some of the expansion of the ethmoid sinuses and even the maxillary sinus, especially the ostium here. You can compare this disease site to the natural opening of the maxillary sinus. So these are some very typical characteristics of CT findings associated with allergic fungal. And again, some of the heterogeneity of the signaling. So it turns out that more bright signal is consistent with the presence of the eosinophilic mucin completely filling up the sinuses that are involved. And again, these patients typically present at a much younger age, at around less than 30 years of age. So another classic imaging is the expansion of the sinuses, as well as the bony erosion that can happen due to the expansion of the sinuses. So on this CT scan, we see a patient with these really enlarged frontal sinuses that have been expanded posteriorly, and then some of the bone erosion that we see and the heterogeneity that we see. But another very characteristic finding is if you got an MRI in this patient, you get what you'll see is this drop signal on the MRI. So you would think that this is an undiseased or minimally diseased sinus cavity, but you know that on the CT scan, that's not in fact what's going on. It's this eosinophilic mucin that has a very high protein level that causes this signal to drop out in this frontal sinus. And then you've got the inflammation that's showing up right here on the MRI involving the other frontal sinus. So this is a classic, again, characteristic imaging for AFRS. So let's talk a little bit about the eosinophilic mucin. As I mentioned, this is a characteristic finding associated with AFRS. So here's a video that really highlights some of the features that people talk about with this mucin. So this is an image on the patient's right-hand side. The middle turbinate is visualized here on the right side of the screen. And you see this suction going into this ethmoid cavity. And this is the characteristic, really tenacious eosinophilic mucin that we find in allergic fungal, at least in the classic presentation of it. So, and then if you took that mucin and put it underneath a microscope, what you'll see is just a chock full of eosinophils, as well as these Charcot-Leyden crystals associated with these degranulated eosinophils, as well as probably finding the actual fungal hyphae within the mucin. But you can see, from a treatment perspective or a surgical perspective, some of the potential challenges associated with this is that, it's so mucinous and so sticky that it's very difficult to clear, and you'll have to be prepared with a slew of different techniques in your armamentarium in order to make sure that you're able to clear all this mucin. Because it turns out that if it doesn't get cleared, then the risk of recurrence of disease and possible revision sinus surgery goes up significantly. So, as I've mentioned, allergic fungal rhinosinusitis seems to be a unique phenotype, endotype of other CRS with nasal polyps. And so this is a nice table that compares allergic fungal rhinosinusitis to other CRS with nasal polyps. And so, of course, both of these entities, polyps, are present, and they both have a similar type 2 immunologic profile, meaning high levels of eosinophils within the inflamed tissue, high levels of mast cells, as well as the cytokines associated with the disease, meaning elevated IL-4, IL-5, and IL-13. Now, the age of presentation can be very different. So AFRS patients typically present much younger. In fact, the youngest patient that I saw with allergic fungal rhinosinusitis so far and operated on was a 7-year-old. So they can present very young. So generally less than 30 years of age, while CRS with nasal polyps more commonly present in an older group, at least greater than 30 years of age. I alluded to this elevated serum IgE levels. So not only do you see patients with AFRS having elevated fungal specific IgE levels, but their total serum IgE levels are often very high. So you'll get, sometimes in the 1,000 international units per milliliter, where typically in other CRS with nasal polyp patients, that serum IgE level is dependent on the patient's atopic status. Also, interestingly enough, when you look at the tissue for both of these disease types, you'll see elevated eosinophils. However, in allergic fungal rhinosinusitis, the serum eosinophil levels are often normal. Excuse me. However, in CRS with nasal polyps, one of the biomarkers or markers associated with really severe disease, as one would expect with allergic fungal, their serum eosinophil levels, the CRS with nasal polyps, are commonly elevated above normal levels. So that's one unique separation. And finally, although the original 1987 paper described these 15 patients, most of which had asthma, it turns out that the prevalence of asthma is very different in AFRS patients versus other CRS with nasal polyp patients. So we did a retrospective as well as a prospective study in which asthma was actively diagnosed using spirometry, that in fact, AFRS patients, the prevalence of asthma was around 20%, while in other CRS with nasal polyp patients, that asthma prevalence can be as high as 60 to 80%. So very different, and we don't understand quite why that is. And it's not because of the young presentation, the age of presentation in allergic fungal, because if you follow these patients out for as they get older, they don't necessarily develop asthma. So moving away from the diagnosis and clinical presentation, hopefully you've kind of now gotten a picture of, what these patients look like. And I'll tell you, we just don't have enough time to go into all the details, but there is a little bit of controversy as to, the actual, the diagnosis of allergic fungal. There may be a spectrum of presentation, but in the South, this classic presentation is a young patient who can present with unilateral, but can also present with bilateral disease of polyps, filled with the diseased sinuses filled with this thick, tenacious eosinophilic mucin, with sinuses that are often expanded with thin bony erosion in these involved expanded sinus cavity. So moving from that presentation to now treatment, let's talk about, what is the best treatment for allergic fungal rhinosinusitis. And so, unlike other CRS with nasal polyps in which medical therapy is the first line treatment options, right? You'll do saline irrigations, maybe nasal steroid sprays, but definitely a course of oral steroids, or at least considering oral steroids and possibly oral antibiotics, and then determining whether or not these patients respond, and then proceeding to sinus surgery for those that don't respond. Allergic fungal rhinosinusitis, surgery is often the first treatment option because, as you saw, this really thick eosinophilic mucin is very difficult to eradicate with just medical therapy alone. So even if you gave someone oral steroids and were able to shrink these polyps present, the mucin doesn't come out of the sinuses very easily because, as you saw, the really tenacious nature of the mucin, the stickiness of it, makes that option not very likely. And so therefore sinus surgery is usually recommended first, followed by medical therapy, because as we know, surgery is often not curative for these patients, and they do need some continued medical therapy to keep these polyps from coming back. So what are the goals of surgery? As I've mentioned, it's not curative, but some of the goals listed here is, to remove that eosinophilic mucin. As I noted, there's a huge fungal burden within that mucin, and it's thought to trigger the inflammatory response. So if that is left behind, That is one of the main reasons why these polyps recur so quickly in these patients if the mucin is not adequately cleared from their sinuses. In addition, acquiring the mucin will help with the diagnosis and confirmation of the allergic fungal rhinosinusitis. Also, another goal is to clear the nasal polyps. Obviously, this will help a patient breathe better through their nose and minimize sinus pressure, pain, and congestion. So that's another key goal of the surgery. And finally, to provide access to topical therapy. As I'd mentioned, the surgery is not curative. And so at this point in time, anti-inflammatories in the form of corticosteroids, whether topically or oral steroids, are often necessary to keep the polyps from recurring. So some of the unique surgical considerations when embarking on a surgical case involving an allergic fungal rhinosinusitis is some of these things to keep in mind. Number one, and we've already talked about, is that eosinophilic mucin is extremely thick and tenacious. So we'll talk about various different tips or techniques in order to make sure we really eradicate it. Because going up to that first point, if it doesn't get completely cleared, the risk of recurrence is much higher. And so you need to keep that in mind. Also, I'll show some CT scans of some classic patients with allergic fungal, but this bony erosion or thinning of the bone and the expansion of the sinuses is something to really to keep in mind, right, in terms of managing an AFRS patient. Do we have the right instruments? A lot of times, if the frontal sinus is expanded significantly superiorly, our classic instruments, our classic even frontal sinus instruments are very difficult to reach up into these extended cavities. So there may be other instruments or equipment that you might need to consider in order to make sure that you meet this goal of eradicating this mucin. And finally, AFRS can present with unilateral disease. And as such, what do you do about that non-disease sinuses or the septum? And those are some things that you need to keep in mind. So over the years, I've learned that this mucin can be very challenging to work with, but some of the things that have worked are utilizing things to consider is a microdebrider to clear all the polyps, right? So in CRS, with other CRS with nasal polyps, for example, in the maxillary sinus, it may not be important to really get all the polyps out of the maxillary sinus or other sinus cavities, because you're going to be, as long as the sinus is widely open, you're going to be applying either topical or oral steroids to these patients. But in allergic fungal rhinosinusitis, the mucin, which can be triggering this inflammation, can be hidden within the polyps. So it's really important to have address all those polyps and remove as much of that as possible, because you may be leaving pockets of mucin within these polyps. And the microdebrider can still be very effective in that scenario. In some situations, I've used pledgets to sort of wick out mucin in areas that are hard to reach. So if you think about the really, especially in an expanded maxillary sinus, if it's expanded laterally, some of our instruments are anteriorly. If there's mucin present there, it's very difficult to reach. And so using pledgets placed into the maxillary sinus and then our instruments to sort of kind of scrub that out can be very effective. Also, using frontal instruments in the maxillary sinus, right? They're more extended, they're angled. So using some frontal instruments can be very effective to reach some of the places, especially in the maxillary sinus or the posterior ethmoid sinuses that are difficult to reach with the classic instruments that we use for those sinuses. Another tool that can be helpful is just using warm saline irrigations on a syringe to help sort of wash out or power wash some of the mucin out of the respective sinuses. That can be very effective. Also, after surgery, I'll often irrigate all the sinuses out to make sure that there's not mucin that, even small bits of it within the sinus cavity. There are instruments that allow you to just more easily irrigate the sinus cavity with a spraying type of device, but irrigation on a syringe can work very well as well. And finally, it's really important to evaluate the sinuses with more angled scopes that you may not normally use. Like, so for example, in the maxillary sinus, it's common to use a 30 and a 45-degree scope, but I'll even go in with a 70-degree scope because some of these expanded sinus cavities, you won't be able to see all these different angles without utilizing these angled, more angled degree scopes. So here's a nice video of the patient's left maxillary sinus that's been opened up. And I'm using a 70-degree scope to make sure that I can get complete view of the entire sinus. So you're seeing the posterior and the superior wall, but now you see this lateral wall. And then just short before that, you saw the angle between the lateral and the anterior wall, the maxillary sinus. And again, you just want to make sure that there's not any mucin trapped in these little corners. And then you can also use the 70-degree scope to look downward rather than to the side and make sure that the floor of the maxillary sinus is also cleared of any mucin. So here's a classic CT scan of an allergic fungal rhinosinusitis, where you'll see this really dramatic expansion and erosion of bone that you don't necessarily need to worry about in other CRS with nasal polyps. So this is a CT scan of a patient with allergic fungal rhinosinusitis, and you can see the expansion of the frontal sinus, erosion of the bone between that and the skull base, the lamina being expanded out and thinned out. You know, this posterior ethmoid cell sort of expanding out above the orbit here. That's not typical. You've got this erosion over the eye. You've got some, really expanded posterior ethmoid cells here. So this is a common finding that we see in allergic fungal rhinosinusitis, and can be very intimidating at first. But I'll tell you that luckily, despite the fact that there's bony erosion, oftentimes or rarely do you have to worry about a CSF leak, although you always should be prepared for that. Even though the bone may have been thinned out and even eroded completely, you still have an intact dura and an intact mucosa layer. And so therefore the risk of a CSF leak is low, although the risk may be higher for an iatrogenic produced CSF leak if you're not aware of those areas of bony erosion or thinning boning, and you're too aggressive in your surgical manipulation in those areas. And again, just kind of going through that talk about, my discussion about, this bony erosion doesn't necessarily imply a CSF leak. Here you see some erosion here, very common. This patient had a prior craniotomy for facial trauma from a separate incident. But even in this patient, there wasn't necessarily any brain fluid leaking due to this erosion from the allergic fungal patient. So another surgical consideration is the fact that the expansion of the sinuses can actually make some areas more easier to approach than your typical sinuses. So for example, the frontal sinus here, you can see that in this patient, the frontal ostium has been widely expanded, making access to the frontal sinus a little bit easier than normal when in some patients where you can have an osteotic frontal ostium. However, this expansion can also create atypical cells or trapping of mucin or inflamed tissue. So you can see here, this may have been an expanded suprabular cell that went up into the frontal sinus. But if you weren't aware of this bony ledge and you didn't get into this cell, there may have been some mucin or the cell being blocked that wasn't that you didn't appreciate. But this only happens because of the sheer expansion or abnormal expansion of other cells. So it's really critical to review that preoperative CT sinus scan so you have an idea and appreciation of some of the abnormal anatomy that has the abnormal expansion that has taken place, and what you will need to do to really get a complete clearance of the sinus cavity. So going back to this unilateral presentation, the fact that we know that that fungus can trigger this inflammation, it's really important, at least for me, not to instrument the opposite side. Sometimes, though, these patients will develop disease on the opposite side. However, there's many patients that I've operated on with unilateral disease that do not develop disease on the other side. And so I don't want to be the instigator that causes this inflammation. So as such, I don't instrument the non-disease side. And even though they may have a deviated septum, I will not do a septoplasty at the time of the surgery for eradicating the mucin from the diseased sinuses. So either that needs to be staged based on the patient's symptoms or just avoided altogether. So now that we've talked about the surgery, I want to go now to think about the post-operative care, right? So again, unfortunately, the surgery doesn't cure the patient of their inflammatory disease. And so it's really important the post-operative care is also critical. So it turns out that 100% of the time, within a year, a patient will have recurrent nasal polyps if they're not treated post-operatively with some sort of anti-inflammatory, because the surgery in of itself causes inflammation. So, but you know, initially at the beginning, when we were treating these patients, we were giving them oral steroids for months at a time. Over time, recently, at least I can say that I've gone from, you know, giving these patients steroids for oral steroids for, you know, maybe 2 to 3 months, maybe even longer. I've now really gone down to a very minimal oral steroids, maybe 9 days or at most 2 weeks of oral steroids after surgery. But the duration is very unclear. And the reason why is I've switched over from oral steroids to more topical steroids as more topical steroids and different delivery mechanisms have become available over the years. But it's really critically important that, you know, again, the post-operative care and the intraoperative care, because the surgical revision rates have been found to be higher in AFRS patients than other CRS with nasal polyp patients. So in a meta-analysis done by Dr. Schlosser's group that looked at over 35,000 patients with CRS with nasal polyps, the surgical revision rate seems to hover around 18 to 20%. However, if you look specifically at allergic fungal rhinosinusitis patients, those surgical revision rates are higher at about 28 to 30%. So how are some ways that we can deliver oral steroids, or corticosteroids at the time of surgery? So one of those are packing material. We can, so once we completed the operative goals of clearing the mucin and the polyps, one of the key ways to minimize the recurrence, you know, dealing with this recurrence and revision issue, is to provide anti-inflammatories at either intraoperatively or also post-operatively. So some of the options that we have, at least in the United States, is to provide packing that has steroids that can release the steroids locally into the inflamed tissue, right? Because surgery in of itself causes inflammation. So we have these steroid-eluting stents that we can place into the sinus cavity that will release the steroids. I usually will have these steroid stents removed within about 2 to 3 weeks because of the fact that the steroids basically are all gone from these stents within 2 weeks. And if you wait longer than that, taking them out becomes much more challenging. So I'll usually remove it within 2 to 3 weeks after surgery. I'll have the patient do saline irrigations at least 2 to 3 times a day immediately after surgery, and then ultimately getting them down to twice a day. And then, you know, after a year or so, you know, trying to find a regimen, maybe once a day should be sufficient. After the stents are removed, I'll have the patient start on topical steroids. And then unless, of course, there is significantly more inflammation, then I may go to an oral steroid. But basically, the goal is to provide anti-inflammation medicine in order to calm the mucosa and as it's healing from the surgery. And hopefully you've cleared all the mucin so that the triggers for inflammation is no longer present. So some key points and some take-home messages is that clearly allergic fungal rhinosinusitis is a unique endotype phenotype of CRS with nasal polyps. And with that, there are several unique aspects when you're thinking about its treatments, which I've highlighted. Sinus surgery, unlike sinus surgery, is the first step in allergic fungal rhinosinusitis, unlike other CRS with nasal polyps. And again, it's because of this management of this eosinophilic mucin that's laden with the fungus. And it's this first step of, this initial step, or the key step in surgery, is to really clear all this mucin from the sinuses, which can be quite challenging, not only because of the tenacious nature of the mucin, but because of the abnormal expansion of these sinuses can create areas where the mucin can get trapped, or inflammation can persist. Also, the bony erosion and the expansion of the sinuses makes another unique aspect of managing AFRS patients surgically very challenging. Although the risk of CSF leak is relatively low, just because of just having the presence of these bony erosions doesn't necessarily imply that you're going to encounter a CSF leak. However, you obviously need to be cognizant of those weakened areas, because it may increase your risk of developing an iatrogenic CSF leak if you're too aggressive in those areas. And finally, the post-operative medical therapy is critical in minimizing the recurrence of symptomatic nasal polyps that may result in revision sinus surgery. So with that, I will leave you with this list of suggested readings. Some of these readings go in. We didn't have time to really talk about some of the research that's been done in allergic fungal, but there's some better understanding these days about molecularly how fungi can lead to this type 2 immune response characteristic of allergic fungal rhinosinusitis, and then go over some of the current controversies as to the spectrum of the disease itself, what exactly constitutes allergic fungal, and then going over some of the treatment options that we've talked about, as well as some potential utilization of some of the more novel therapeutics that are available for CRS with nasal polyps, specifically alluding to, the role, if any, of biologics in allergic fungal. So with that, I will end, and thank you so much for your time.